Welcome to the Deep Dive. Today, we are immersing ourselves in a topic that lives right at this really complex, sometimes frightening intersection of psychology and medicine. We're talking about factitious disorder, maybe better known by its older name, Munchausen syndrome. Now, this is a deep dive that, well, it demands sensitivity because we're really confronting deliberate deception, but the highest stakes setting you can imagine, a hospital, a clinic. Our mission today is to move beyond maybe the sensational stuff you hear sometimes and gain a really thorough, non-judgmental insight into what is a serious mental health condition. It's characterized by fabricating or even inducing illness. We really want to look for the why behind this medical mystery. So let's start right at the beginning. What exactly is factitious disorder, or FD, based on the sources?
Okay. Fundamentally, FD is defined as a psychiatric condition. It's where individuals intentionally, deliberately produce or fake physical or psychological symptoms. Their motivation is really strong. They want to adopt the identity of a patient, to portray themselves as genuinely ill or hurt or impaired.
And why do they want that? What's the game?
Well, that perceived illness grants them access to attention, sympathy, and often, quite invasive medical resources.
Right, and this is the point we absolutely have to nail down right away, because I think a lot of people hear deliberate deception and they immediately think, okay, criminals, insurance scammers, that kind of thing. Why is this defined as a mental illness and not just, manipulative fraud?
That difference is the absolute key defining feature. And it really rests entirely on the incentive, or rather, the lack of one. For factitious disorder, there has to be a complete absence of obvious external incentives.
Okay, so what counts as external?
Things like obtaining disability payments, getting out of work, maybe trying to win a lawsuit, or crucially, obtaining specific drugs like narcotics. If that's the motivation, then it's categorized differently. That's called malingering. It's a different behavioral pattern driven by tangible external gain.
Got it. So the FD patient isn't faking it for money or to avoid prison or get painkillers. They're motivated purely by something internal, a psychological reward of being in that sick role.
Exactly. The reward is entirely intrinsic. It's the validation, maybe the care, that sense of belonging that comes with being seen as a dependent patient. The behavior is its own reward, in a way. And that's why it falls squarely under psychiatric diagnosis.
Which makes the reality of it, like you said, much darker.
Absolutely, because the patient is often willing to endure really serious medical risks, painful procedures, complications, even potentially death, just to maintain that psychological state.
And factitious disorder isn't just one thing, right? It manifests in two main forms, depending on where the deception is aimed.
That's right. We generally separate it into two categories. First, there's factitious disorder imposed on self, or FDIS. That's where the individual fabricates symptoms in themselves. This is the classic Munchausen case most people think of.
Okay. And the second?
And then there is the severe, and you could argue, much more disturbing form, factitious disorder imposed on another, or FDIA. This happens when a caregiver, and it's almost always a caregiver, fabricates or actually induces illness in someone dependent on them, usually a child, sometimes a vulnerable adult, or, there are even documented cases involving pets.
Wow. Okay, let's focus first on FDIS, the self-imposed kind. This is what most listeners probably recognize as Munchausen syndrome. We should probably touch on the history of that name, too, because it paints such a dramatic picture, doesn't it?
It really does. And the name itself gives you some insight into the dramatic nature of the disorder. It was coined after Baron Munchausen, who was an 18th century German nobleman.
The guy with the tall tales.
Exactly. He was notorious, basically, for being a pathological storyteller, famous for telling these incredibly elaborate, outlandish, wildly exaggerated stories about his adventures, military stuff, hunting, defying physics. The name stuck because it seemed to perfectly capture that theatrical, fabricating nature of the illness narrative these patients present.
And Munchausen syndrome isn't just any FDIS diagnosis, right? It's described as the most severe chronic form. How does that specific subtype differ from maybe a less chronic case of factitious disorder?
Well, the Munchausen pattern, it's characterized by really profound chronicity and severity. And there's a specific defining behavior associated with it known as peregrination. These are individuals engaged in this chronic, intentional deception to present as desperately critically ill. They pose immense diagnostic challenges because their clinical findings are often chaotic, inconsistent.
Peregrination.
Yeah.
That's the medical traveler, right? The person who constantly leaves one hospital just to start the whole process again somewhere else. What drives that specific pattern? It must be exhausting, this hospital hopping.
It's driven fundamentally by the need to maintain the facade without getting caught, without being exposed. As medical professionals in one place start to connect the dots, they notice inconsistencies. Maybe they discover records were withheld, or they just recognize the pattern of unexplained decline. The patient flees.
So they just pack up and go.
They wander from hospital to hospital, city to city, always seeking new treatment settings and actively avoiding disclosure of their extensive, often fraudulent, past medical care. The sources actually use some really striking language here. They describe the afflicted as the fascinating derelict, human flotsam detached from its moorings, the peripatetic medical vagrant, the itinerant fabricator of nearly perfect facsimile of serious illness.
That's quite a description. Human flotsam. It really underscores that this patient identity becomes their entire life, their anchor almost.
It does. It suggests this complete detachment from any kind of stable, normal life, yet they're perpetually attached to the medical system itself.
Logistically, though, how do patients keep this up? Doesn't the cost, the movement of medical records, eventually catch up and break the facade?
Well, that's precisely the weakness in the system they exploit so well. They become masters at manipulating the gaps in communication, especially when moving between different states or different health systems. They often pay cash for initial visits, maybe claim to be new to the area. And they employ this pathological lying mechanism. It's called pseudologia fantastica.
Pseudologia fantastica.
Yeah.
Okay, what does that involve?
It means they fabricate these detailed, highly imaginative falsehoods, not just about their illness, but about their entire personal history, their supposed education, prestigious jobs, complex life events.
So initially, they present a really dramatic, compelling story.
Absolutely compelling, often enough to convince initial physicians. But the story tends to fall apart under scrutiny. When a clinician tries to verify the details, personal, educational, medical billament, the patient often becomes vague or defensive, sometimes hostile.
That must be a huge red flag.
It is. That pattern of evasiveness, combined with refusing to allow contact with prior providers, often claiming they've retired or suddenly moved, that's a major warning sign for clinicians.
And if the patient is pursuing this identity through invasive means, the deception can actually leave physical marks, irreversible evidence on their body.
Oh, frequently, especially in the severe Munchausen subtype. Multiple surgical interventions are unfortunately quite common, often for invented acute abdominal crises or maybe unnecessary organ removals. These procedures leave numerous scars, so much so that clinicians sometimes refer to the visual result as a gridiron abdomen.
A gridiron abdomen.
Yeah.
Like a football field.
Yeah, that pattern left by repeated, often completely futile operations undertaken solely to maintain the credibility of that sick role. It just shows an extreme willingness to endure pretty significant physical harm in pursuit of this psychological validation.
Okay, this is where it gets really interesting and maybe quite difficult. We need to move from what they do, the lying, the hospital hopping, even the self-harm, to the really complex why. What are the leading ideas, the psychosocial hypotheses driving this kind of behavior?
The focus is overwhelmingly psychological. It seems rooted in early life experiences and how their identity developed. The leading hypotheses really emphasize this profound, chronic desire for attention, and maybe the safety provided by adopting that dependent sick role.
And what kind of really experiences are we talking about?
Well, looking at patient histories, some common factors tend to emerge. Things like a history of traumatic childhood experiences, maybe profound early loss of a loved one, or just pervasive, overwhelming feelings of neglect and abandonment.
So at the hospital, it almost becomes a substitute, a place of refuge, providing the care they maybe never got at home.
That's the main theory, yes. By fabricating serious illness, they gain access to sustained, non-judgmental attention and care from healthcare professionals. Care that might have been conspicuously absent in their formative years. Think about it. The sick role is highly structured, you're cared for, you're generally believed, your needs are prioritized. It seems to secure a sense of belonging and validate an identity that the person feels incapable of getting through, normal, healthy, social ways.
Does a history of actual illness play a role?
It can, yes. A history of serious childhood illness or maybe extended hospitalization might also play a part. It could make the hospital environment feel familiar, almost comfortable in a strange way, a place where dependency was once legitimately rewarded.
Okay, so the deception is intentional, clearly, but the motivation seems almost unconscious, or at least uncontrollable. Given that complexity, how common is this disorder? And why is it apparently so hard to measure accurately?
Accurate numbers are incredibly difficult to get. primarily because of the secretive, deceptive nature of it. If the patient is successfully deceiving the system, well, they don't end up in the data set, do they? However, some studies have managed to identify FDIS in about 1.3% of all hospitalized patients.
1.3%. That actually sounds significant considering how many people are hospitalized.
It is a significant number. And the severe Munchausen subtype, that seems to account for about 10% of those diagnosed cases. But the medical community really struggles, not just with underdiagnosis, but also with establishing a clear, measurable threshold. Like how much deception is needed for a formal diagnosis. It's tricky.
Are there specific demographic factors, things that might put someone at higher risk for factitious disorder?
Yes, there are some interesting patterns in the data. For general FDIS, the associated risks tend to include female gender and being unmarried. And crucially, we often see employment within the healthcare field.
That makes sense. Why is that a risk factor?
Well, it provides two major advantages, really. First, the medical knowledge you need to convincingly fake complex symptoms. And second, immediate access to medical environments, supplies, maybe even records.
But you mentioned the severe Munchausen subtype earlier. Does that skew differently in terms of demographics?
It does, slightly. The most chronic, traumatic cases, the ones we label Munchausen, they show a higher risk for male sex, single marital status, and a peak age range generally between 40 and 50 years old. And this severe form is often deeply linked with complex personality profiles, specifically antisocial personality traits and characteristics associated with cluster B personality disorders.
Cluster B, that's borderline narcissistic antisocial. Those types.
That's right. Borderline narcissistic and antisocial characteristics are often noted.
That connection to cluster B is really fascinating. How do traits like, say, narcissism or antisocial behavior feed into the mechanism of factitious disorder?
Well, it can be a powerful synergy, unfortunately. Narcissistic tendencies, for instance, involve this deep need for admiration, a sense of superiority, successfully deceiving highly educated medical professionals, the specialists, the surgeons. That can really feed that superiority complex. They might feel smarter, more capable, more in control than the system they're manipulating.
And the antisocial traits.
The antisocial traits could contribute to the lack of remorse or empathy. Regarding the high cost, the unnecessary resource drain their deception causes. The patient might find great satisfaction not just in receiving care, but in demonstrating their power over the system.
The behavior itself, it sounds like this compulsive secretive pattern.
Sure.
Does the DSM-5, the main diagnostic manual, link FDIS to other disorders that involve that kind of persistent hiding?
Oh, absolutely. The core behavioral pattern of FD shares key characteristics with conditions like substance use disorders, eating disorders, impulse control disorders. In all of these, the patient engages in a destructive pattern that requires intense, intentional deception and concealment efforts to hide what they're doing from others, whether that's drug use or purging, or in this case, symptom fabrication. It's a core pattern of destructive secrecy that really dictates their life.
And because their goal is medical attention, not psychiatric help, these patients probably rarely walk into a therapist's office first, right? Which medical specialties are they most likely showing up in?
That's right. They usually present with somatic symptoms, physical symptoms that allow them to kind of conceal the underlying psychological distress. So that makes non-psychiatric specialties the first point of contact. Our sources indicate that dermatology and neurology specialists are highly sought out.
Dermatology and neurology, why those specifically?
Well, think about the symptoms they can present in those fields. Things like chronic rashes, unexplained numbness or weakness, seizures, complex chronic pain. These are often symptoms that are really difficult to definitively prove or disprove objectively with a simple test, which puts the burden of identification squarely on those non-psychiatric clinicians. The ER docs, primary care physicians, the specialists, they have to become medical detectives, essentially.
That must make the diagnostic process incredibly stressful for the doctors. They're trying to solve a medical mystery that, in reality, is an intentional fabrication.
It really is the ultimate diagnostic challenge. The vast majority of FDIS presenting symptoms just cannot be confirmed by standard lab tests or imaging. The patient actively works to confuse the physicians, often presenting with a spectacular array of conflicting clinical findings that just don't fit neatly into any established disease model. They seem to thrive on being the unique, medically complex, undiagnosable patient.
So if the tests aren't ruling it out, what are the actionable red flags, the things medical professionals are trained to spot? What are those key inconsistencies?
Well, a pattern usually emerges over time. First, there's often a glaring mismatch between how severe the patient says their symptoms are and what objective physical findings or lab results actually show. Second, resistance to collaboration. They won't provide previous medical records, or they claim prior providers are unreachable, retired, moved away, records lost.
Okay, what else?
Third, and this is highly telling, the patient's condition mysteriously, sometimes precipitously, declines whenever a discharge date is discussed or even scheduled. They just can't afford to lose that patient role.
Anything else clinicians look for?
Yeah, other major indicators include maybe a lack of interest when test results come back positive or reassuring, or the sudden, inexplicable onset of a completely new, complex symptom right as the original symptom was starting to resolve. We also see cases, for instance, of anemia that mysteriously fails to improve even after multiple blood transfusions, or symptoms the patient claims only happen when they're alone, or symptoms they can oddly predict the timing of.
Interesting.
And another thing is, they often have very few, if any, visitors during sometimes long hospital stays. Despite often claiming to hold important, prestigious jobs or have large families outside the hospital, the story just doesn't add up.
Okay, to really bring this pattern to life, let's look at a specific and potentially dangerous clinical example mentioned in the sources. Factitious hyperthyroidism, also called factitious thyrotoxicosis.
Right. This is a really textbook example of FDIS. It's where the patient has enough medical knowledge to convincingly mimic a systemic illness. What happens is the individual intentionally and secretly takes excessive doses of thyroid hormone medication, something like levothyroxine, specifically to induce the symptoms of a hyperactive thyroid gland.
And what makes those symptoms so convincing to doctors initially?
Well, they're powerful and they affect the whole body. The patient might present with a rapid heartbeat, severe anxiety, nervousness, maybe heat intolerance, unexplained rapid weight loss, chronic diarrhea. To the untrained eye, or even an initial clinician, this looks exactly like genuine hyperthyroidism.
So how does the medical detective figure it out? How do they differentiate between a genuine illness like Graves' disease and this intentional deception?
The differentiation relies heavily on looking closely at objective clinical signs and some specialized lab markers. While the symptoms are similar, genuine hyperthyroidism, which is often caused by Graves' disease, usually comes with other physical signs. Things like a goiter, that's an enlarged thyroid gland in the neck, or maybe ophthalmopathy, which is that characteristic eye bulging. Factitious hyperthyroidism typically lacks these specific physical markers.
Okay, so the physical exam is one clue. What about lab tests?
The lab tests can provide the real smoking gun. Thyroid function tests will confirm, yes, there's excess hormone, but other markers can reveal its external source. Specifically, doctors look for low levels of thyroglobulin. That's a protein that's naturally produced inside the thyroid gland. So if you have low thyroglobulin but high thyroid hormone levels, it strongly suggests the body isn't making the hormone, it's coming from outside.
Ah.
And furthermore, doing a test like a radioactive iodine uptake scan will usually show reduced uptake. This confirms the thyroid gland itself is quiet, it's not overactive, because it's not being stimulated by the brain. Again, suggesting the hormone overload is external.
And the motivations for this specific type, factitious hyperthyroidism, sometimes they go beyond just wanting the sick roll right.
Yes, that's true.
I-
While it absolutely serves the primary purpose of securing medical attention and the patient identity, factitious hyperthyroidism is also seen specifically in the literature related to athletes and bodybuilders, people who are seeking an accelerated metabolism, maybe to manage weight or fat loss.
But regardless of the trigger, it's dangerous.
Immensely dangerous. Regardless of the immediate motivation, the underlying risk is huge. Excessive thyroid hormone exposure can lead to severe cardiac complications like atrial fibrillation, brittle bones, or osteoporosis, and potentially fatal cardiac arrhythmias. It's not a harmless deception.
Definitely not. Okay, now we need to make a really profound shift. We're moving from FDIS deception focused on the self to FDIA, factitious disorder imposed on another. This takes us out of the realm of self-harm and into intentional abuse, harm directed at the most vulnerable people.
Yes, the shift is ethically and legally enormous. And we should probably recap the terminology again because it can be confusing. The current term in the DSM-5 is factitious disorder imposed on another, or FDIA. This replaced the older, more famous term, Munchausen syndrome by proxy, or MSBP. Clinically, you might also hear it called medical child abuse, or fabricated or induced illness by carers FII. But the critical point always is that the diagnosis of FDIA applies only to the perpetrator, never the victim.
The gravity of FDIA.
Yeah.
It's just impossible to overstate, isn't it? What makes it one of the most dangerous forms of abuse out there?
It's lethal precisely because it operates under the cloak of caregiving. It's incredibly covert, hard to detect, and devastatingly deadly. The sources document a chilling and pretty consistent mortality rate of between 6% and 10% for the victims.
6 to 10% die.
Yes, these are intentional acts of harm, driven purely by the caregiver's psychological need for attention, sympathy, validation. The same core psychological reward system we see in FDIS, but it's redirected externally onto someone else.
Let's try to analyze the profile of the FDIA perpetrator. Who is typically involved? And what behavioral signs do they tend to exhibit in the medical setting?
The profile is starkly consistent across studies. Over 90% of cases involve the mother as the perpetrator. Some studies cite numbers like 76.5%, specifically being the mother, and they often target very young children, preverbal children, or kids under age 6 usually.
And how do they act in the hospital? How do they stand out?
In the hospital, these perpetrators often appear unusually knowledgeable, almost encyclopedic about medical issues, procedures. They tend to interfere extensively with the child's care, often questioning or challenging medical decisions.
And their demeanor, I've read, it's often paradoxical. They seem unnaturally calm when their child is supposedly facing a major medical crisis.
They absolutely do. It's quite eerie. They often appear overly devoted, almost thriving in the hospital environment. That's where they seek maximum sympathy and attention for their heroic efforts in dealing with this complex, confusing illness their child has. This perceived heroism really validates their identity.
Are there patterns in the family dynamics?
Yes, often we see patterns involving isolated mothers, maybe, and fathers who are either described as conflictual or perhaps uninvolved or just absent altogether. And critically, many perpetrators have personal histories of factitious disorder imposed on self, or they themselves suffered unresolved childhood trauma, like abuse or neglect. It's often a cycle.
Let's detail the actual methods of harm. The sources divide this into active induction of illness and then fabrication or simulation.
Yeah.
What does active induction involve?
Induction is the calculated act of actually causing illness or injury. This is where the deception becomes profoundly dangerous and, frankly, quite horrific. Examples include secretly administering medications that aren't prescribed, or poisons or dangerous substances like giving insulin to cause seizures or life-threatening hypoglycemia. There are documented cases of perpetrators injecting bacteria or unsanitary matter, things like feces, into the child's 5V line or under the skin to deliberately cause abscesses, chronic fevers, or sepsis. Induction can also involve direct physical harm, like suffocation, which causes unexplained apnea spells or near-death events, or intentional starvation leading to severe malnourishment.
The cold, calculated nature of these acts, committed by a primary caregiver, it's truly hard to comprehend.
It really speaks to the utter dominance of that psychological reward system. It overrides the basic maternal or parental protective instinct. The immediate goal seems to be creating a legitimate, serious clinical emergency, something that will land the child in the intensive care unit because that secures maximum immediate attention for the devoted parent.
And then on the fabrication side, they're manipulating data and symptoms, not directly causing harm.
Correct. Fabrication involves things like falsifying the medical history provided to doctors, exaggerating minor symptoms into seeming life-threatening emergencies, or actively manipulating evidence. This is where we might see tampering with test results, maybe adding blood or other contaminants to urine or stool samples, or deliberately heating thermometers, say, on a bedside lamp, to fake a high fever just before the nurse comes in.
And their medical knowledge helps them hide this.
Exactly. Their medical expertise, often gained through prior healthcare employment or just hours and hours of internet research, makes them highly effective at concealing their methods. They know what looks plausible.
So when clinicians start to suspect FDIA, maybe because things just aren't adding up, what are the critical warning signs they look for in the victim, in the child? What should trigger an investigation?
The key, again, is inconsistency, much like FDIS, but magnified because it involves a third party. First, you see symptoms that are mysterious, complex, they don't fit any known disease pattern, or they refuse to correlate with objective test results time after time. Second, and this is perhaps the single most telling indicator, The child's condition improves dramatically, sometimes almost overnight, when they're under the care of medical staff and the caregiver is separated from them.
Oh.
But then the symptoms inexplicably return or worsen dramatically once the child is back home alone with the perpetrator.
So the hospital actually becomes the safest place for the child in these situations.
In many cases, yes, tragically. You also often see a history of repeated hospitalizations, many painful and invasive procedures, sometimes even things like organ removals that never yield a definitive diagnosis or cure.
And the warning signs in the caregiver themselves, do they often mirror the red flags we talk about for FDIS, the self-imposed version?
Yes, quite often. It's that compulsive need to control the narrative and be the center of medical attention. So, warning signs include excessive involvement and familiarity with medical staff, constantly seeking attention and praise for their dedication, and critically, that tendency towards doctor shopping or hospital hopping. They keep moving until they find a doctor or hospital that will give them the diagnosis or perform the procedure they're seeking.
And that pattern of the condition worsening near discharge.
Exactly. Just like with FDIS, the child's condition often declines sharply right as discharge is imminent. It seems to reflect the perpetrator's anxiety about losing their stage, losing that source of attention.
The collateral damage here sounds immense, too. It extends beyond just the primary victim, doesn't it? It affects siblings as well.
The statistics here are truly horrifying, and they demonstrate that this is often a systemic pattern of behavior, not an isolated incident. In known cases of FDIA, siblings of the identified victim often have similar unexplained medical issues. The sources say over 60% of siblings are impacted in some way.
Over 60%.
Yes. And most tragically, in a significant percentage of these families, around 25.2%, according to one study, siblings have died suddenly and unexpectedly. This strongly suggests they may have been prior victims of undisclosed harm themselves.
That's just devastating. So the medical world is clearly struggling to detect this complex deception in the real world. Let's talk about how this psychological mechanism has sort of adapted to the modern age, the anonymity and scale of the internet. We're moving into what's being called digital fictitious disorder, or DFD.
Yes, DFD, sometimes called Munchausen by internet, it's a rapidly emerging and frankly concerning form of this disorder. Here, individuals assume the patient role, or sometimes the heroic caregiver role, entirely within online spaces, online forums, support groups, social media platforms.
And how does it work there?
They use the digital space to craft these incredibly detailed, emotionally manipulative, and often very compelling narratives of illness or injury, either about themselves or sometimes fabricating stories about their children's conditions. And the goal is the same, to attract sympathy, attention, validation, but from large online communities.
This sounds like it could be far more prevalent than the real-world version. I mean, the cost of entry is basically zero, right? You just need to type a convincing story.
Exactly. The sources strongly suggest this behavior may be far more common online than its real-world counterpart, largely because the bar for concealment is practically non-existent. In the digital realm, you don't need to fake lab tests or actually injure yourself. You just need a convincing narrative and the shield of anonymity.
And the online environment might even encourage it.
It seems to, yes. The environment naturally encourages what you could call group validation rituals, where online sympathy, maybe sending gifts, offering constant emotional support. It feeds the exact same psychological need that a hospital admission does for the FDIS patient, but potentially on a much larger scale.
The scale could be huge.
It's massive. Some reports indicate digital lying in general is far more prevalent than real-world lying. One study looked at digital self-help communities and found nearly half of the respondents reported experiencing fake reports of severe medical crises, things like complicated pregnancies ending in miscarriage. And 15% reported fake claims of death, sometimes the death of a fabricated child. The sheer volume of this kind of deception really highlights how the internet can unfortunately magnify this particular pathology.
And the internet also provides them with all the tools, doesn't it? The medical language, the complex narratives, everything they need to make their stories believable.
Precisely. They can research symptoms meticulously, use all the correct jargon, build a highly detailed chronology of fictitious events, and the virtual environment protects them from the kind of scrutiny that physical peregrination would eventually expose them to. Nobody online can ask to see their scars or demand lab results or try to contact their family. They can become the perfect, tragic, digital victim, garnering thousands of comments, followers, and that instant validation they crave.
This all leads us to the critical final question. Management and treatment. What is the specialized, extremely careful approach required when health professionals do identify fictitious disorder?
Well, the first and probably the most difficult lesson clinicians learn is this. Direct confrontation rarely works. In fact, it's usually counterproductive and can even be dangerous.
Why is that? Why doesn't just calling them out work?
Because the core mechanism of the disorder is the preservation of that patient identity. Accusing them directly of fabricating symptoms triggers an immediate, almost primal defensive reaction. They typically respond with angry denial, maybe hostility, sometimes even threatening legal action, or the ultimate escape, fleeing the facility to continue their peregrination elsewhere.
And fleeing not only prevents them from getting the psychiatric help they need, but it immediately puts them back at risk. They're exposed to new, unnecessary medical tests and procedures in the next city.
Exactly. It completely breaks any continuity of care and forces new, uninformed clinicians to start that expensive, dangerous diagnostic cycle all over again.
So the strategy has to be non-judgmental, finding a way to guide them towards psychiatric help, while somehow sparing them the humiliation of admitting the deception outright. How does a clinician even execute that delicate pivot?
It's incredibly delicate. Healthcare professionals essentially have to pivot the focus, move away from trying to cure the non-existent illness and towards managing the behavioral and functional consequences of the situation. The strategy is often described as creating a therapeutic out for the patient.
And out. What does that look like in practice?
For instance, a doctor might gently assure the patient, saying something like, "Okay, while your medical tests are surprisingly normal now, it's clear you've been under immense stress. And the chronic stress and anxiety of living with such a baffling, unexplained illness may itself be causing these very real physical complaints you're experiencing." The language is crucial. You acknowledge the suffering is real, while gently shifting the treatment focus towards improving overall function and quality of life, maybe through psychological support, rather than continually chasing fabricated symptoms with more tests.
So the goal is always nudging them towards mental health care.
The central goal is always the same. Steer the patient toward consistent, long-term care with a mental health professional, even if that referral is initially resisted or maybe framed initially as treating stress-related symptoms rather than FD itself.
What does that coordinated interprofessional management plan actually look like for a patient who is diagnosed with FDIS?
It absolutely requires a unified front from the entire healthcare team. First, it's crucial to establish a primary care gatekeeper. This should be one trusted, knowledgeable healthcare professional, often a primary care physician, who oversees all of the patient's medical care.
And what's a gatekeeper's role?
Their job is multifaceted: to manage the patient's anxiety, provide structure and consistent contact, but most importantly, to coordinate information across specialists, to try and block unnecessary specialist visits, duplicate tests, high-risk procedures, and especially unnecessary surgical interventions.
Okay, gatekeepers first. What else?
Second, psychotherapy remains the primary treatment mechanism for the underlying disorder. Cognitive behavioral therapy, CBT, is often employed. Sometimes therapy might focus specifically on addressing unresolved childhood trauma or core identity issues. However, the prognosis is often quite guarded. Patient engagement is notoriously limited. Very few patients, the sources note, only a small fraction ever fully acknowledge the diagnosis of factitious disorder, which makes deep therapeutic work extremely challenging.
Are medications used?
Medications are only used to manage co-occurring mental health conditions. Things like severe anxiety, depression, or perhaps personality disorder traits that might be present. But there's no medication that treats factitious disorder itself.
And when the deception is directed at a child FBIA, the management plan completely changes, right? It becomes a mandatory legal process.
It shifts entirely. It goes from being primarily a mental health management issue to a child protection and potentially criminal one. FDIA is a form of medical child abuse. That means immediate and mandatory involvement of Child Protective Services, CPS, is absolutely non-negotiable. Often, the single most effective intervention is the immediate removal of the child from the perpetrator's custody. That separation almost invariably results in a rapid, sometimes dramatic, and sustained improvement in the child's actual health.
And what about the victim, the child after separation?
For the victim, the child-intensive long-term therapy is essential. They need help to cope with the profound betrayal, the confusion, the medical trauma, the psychological trauma, all inflicted by the very person they were supposed to trust the most.
This entire discussion just highlights the enormous strain this disorder places on the medical system, on families, on human trust itself.
It really does. We're talking about significant morbidity, the tragic mortality rate, especially for FDIA victims, the high emotional cost borne by medical professionals who are constantly forced into the role of detective. And of course, the massive financial burden on healthcare systems. All those unnecessary tests, prolonged hospitalizations, complex surgeries, all driven by this desperate, destructive psychological need.
If we try to connect this to the bigger picture, the sheer paradox of factitious disorder is kind of hard to ignore, isn't it?
It is the ultimate contradiction, really. The person with FD or the perpetrator of FDIA is fundamentally seeking something human: belonging, connection, care, attention. Yet their method, masterful, persistent, harmful deceit, inevitably isolates them further. It burns bridges with providers, destroys trust with family, and consumes massive amounts of the very resources they claim to need. They're seeking acceptance through a behavior that guarantees rejection in the long run.
So wrapping this up, what's a final thought for our listeners to take away from this deep dive?
Well, building on that paradox, maybe this. Critical thinking about intent, about motivation, it's clearly vital in medical diagnosis, but perhaps also in our everyday interactions. Given how difficult chronic deception is to detect, especially when that deceit plays into our natural instinctive desire to help or show empathy, and remembering that FD patients often deliberately seek out non-psychiatric physicians, consider how this fundamental human need for connection and validation can, in some extreme cases, drive some of the most complex, resource-intensive, and physically dangerous forms of fabrication we know. It forces us to ask, maybe, how do we reconcile our professional or personal instincts towards empathy and care with the stark reality of intentional chronic fabrication, especially when that fabrication might risk the lives of vulnerable people? It really forces a profound consideration of trust and maybe the limits of empathy in all our human interactions.